Modern healthcare relies on high-speed, complex systems where dozens of professionals must collaborate seamlessly to keep a patient stable. Because these systems rely entirely on human beings, differences in clinical judgment are inevitable. Two experienced providers can look at the exact same chart and arrive at different interpretations. There is a dangerous misconception in medicine that a good clinical team is one that always agrees, or that a quiet staff indicates a safe environment. When a junior nurse notices a dosage error and stays silent to avoid conflict, or out of deference to a senior doctor, patient lives are actively put in danger. Professional disagreement functions as a critical clinical safety feature. It relies on a foundation of baseline rules, staying calm, citing objective evidence, and assuming positive intent from colleagues. But basic courtesy cannot stop an active medical error in real time. To do that, a team requires a systematic protocol to escalate their concerns. Valid safety concerns are frequently missed in the first instance. In a chaotic ICU, a critical warning might simply get lost in the noise, the distractions, or the rigid chain of command. This flowchart illustrates the two-challenge rule, an objective protocol forcing a pause in chaotic moments. First, state the issue assertively. Use an I statement to take ownership. For example, I am concerned about the patient's heart rate. If dismissed, the protocol requires you to advocate a second time. I need to voice my concern again because the heart rate is still dropping. If still dismissed, you activate the final failsafe. You bypass the immediate team and escalate to a senior supervisor. This rule standardizes persistence, making it a mandatory clinical procedure rather than a personal challenge to authority. Getting the team's attention is only the first step. Stands the severity of the situation. This empty pyramid represents the CUS framework, scaling in intensity alongside clinical danger. Level 1 is concerned. Use this collaborative tone for early warning signs. When risk increases, escalate to level 2, uncomfortable. The tone is assertive, making it clear action is needed. If a serious error is imminent, use the final level, safety issue. This commanding tone stops the medical process immediately. It is the difference between asking, "I'm concerned about the bleeding from this extraction site," and demanding, "This is a safety issue. We need to address this bleeding before discharge." The framework cuts through medical jargon, allowing any team member to communicate the exact level of threat to the entire room. Once the crisis is averted and the medical danger is neutralized, interpersonal friction between the staff can often remain. To repair that dynamic, teams use the desk script. It is a structured process used to unpack the conflict and rebuild consensus. You start by describing the specific situation using concrete data. Then you express how that situation affects the safety of the team and patient. Next, you suggest alternatives to reach an agreement and clearly state the consequences to patient safety if unresolved. The desk script repairs the team's morale without personal attacks, ensuring the staff remains cohesive for the next patient. Utilizing these frameworks removes guesswork and personal ego from team friction. These frameworks replace potentially toxic personal arguments with a standardized, objective protocol. This system empowers every person in the room to pull the emergency brake on a dangerous procedure, regardless of their rank. Professional disagreement focuses on finding the right answer for the patient, not on establishing who was right. Structured, respectful pushback prioritizes the patient's well-being, serving as a final safeguard against medical error.